Okay, so I'm Haley, this is Alan and Katie, and we're presenting a case on an 18-year-old woman with acute liver failure. So the patient was a healthy Southeast Asian American. She was 18 years old, and she had mild asthma. She did not report that she smoked, used drugs, or used alcohol. She had a grandmother with a history of unspecified liver disease. And at the time of her illness, when she arrived at the hospital, she was 11 weeks postpartum. It was her first pregnancy, and the child was born premature at 32 weeks due to a placental abruption, which is when the placenta becomes unattached from the uterine wall before delivery and often causes bleeding and exacerbates pregnancy, often a premature pregnancy. She remained hospitalized after her birth for 1 week due to unspecified lab or abnormalities. 1 week prior to her arrival at the hospital for this now current hospitalization, she reported rhinorrhea, which is a runny nose, cough, and sore throat. And then on the fourth day of her illness, she was seen in an urgent care clinic for a worsening cough, wheezing, and dyspnea, which is trouble breathing. She was diagnosed with bronchitis and prescribed a promethazine dextromethorphan syrup and a 5-day course of oral azithromycin. She was then returned home, and over the next 3 days between this diagnosis and her hospitalization, she reported abdominal pain, nausea, vomiting, vaginal bleeding, gum bleeding upon brushing teeth, jaundice, and tea-colored urine. A syncope episode, which is a temporary loss of consciousness, otherwise known as fainting, led to her to get a chin laceration, which her boyfriend then called emergency medical services. EMS, upon arrival, noticed jaundice and diaphoresis, which is excessive sweating. And then upon arrival to the hospital emergency department noticed jaundice again and low blood pressure. Her abdomen, upon examination, was soft and had mild epigastric tenderness, abdominal guarding, and rebound tenderness. One exam they did was Murphy's test, where they press really hard on your liver or on your upper stomach to differentiate right upper quadrant pain, and it was noticeably absent, which eliminates gallbladder. After doing this test and other lab results, there was a diagnosis of acute liver failure. So now I'm going to kind of go over the liver, and then Alan and Katie will talk about her diagnosis. So the liver regulates most chemical levels in the blood and excretes a product called bile. Bile helps carry away waste from the liver, and all the blood leaving the stomach and intestines passes through the liver. The liver processes blood and balances the nutrients to metabolize drugs and other nutrients from what you eat and other ingestions. Also, most dietary copper passes through the liver, where it can be used for protein and energy production, or it is excreted through the bile. When liver has broken down harmful substances or excess substances, the byproducts are excreted into the bile or the blood. Byproducts enter the intestine and then leave the body through feces. Blood byproducts are filtered by the kidneys and excreted by urine. Part of her presentation was tea-colored urine, so this would indicate there was some dysfunction with the excretion of excess something.
So upon the patient's arrival at the hospital, it was very quickly noted, and I'll go into this in a second, that she had acute liver failure. So the timeline to get a differential diagnosis was extremely short. There wasn't time to run the entire workup of tests that normally would have been done. So the doctors had only a very small number of units per liter of different chemicals in her blood to work off of. So it was a very short timeline, and then they had to diagnose and then properly treat whatever was ailing. So the first thing they noticed was that the patient had acute liver failure. So in the past, the patient had no record of liver problems and had an INR level well above 1.5. So INR is a measure of the blood's ability to clot, and a normal person is at 1, and the scale goes up to 5. 1.5 is significant enough to note, but it's not at the point where she's totally unable to clot. It's just a slight statistical significant difference. So that INR level led her to be diagnosed with coagulopathy. The patient also had no hepatic encephalopathy, And while acute liver failure involves this symptom, 50% of pediatric acute liver failure cases do not involve hepatic encephalopathy. So the absence of hepatic encephalopathy does not necessarily push acute liver failure diagnosis to the side. In fact, the fact that half of all cases of pediatric liver failure don't have hepatic encephalopathy means that the doctors could go ahead and diagnose her with acute liver failure despite there being no hepatic encephalopathy. So right off the bat, they diagnosed her with acute liver failure. The next thing the doctors thought they might be able to diagnose with in order to get closer to the final diagnosis was acetaminophen exposure. So the patient was at pre-admittance abuse risk of acetaminophen due to the possibility of postpartum depression and her unplanned pregnancy at a young age. However, there was no history of psychiatric illness to indicate her possibly having an intentional overdose of acetaminophen. And in fact, toxicity reports confirmed that the biochemical factors produced by the ingestion of too much acetaminophen were not present. However, the doctors decided to treat her with a drug, N-acetylcysteine, that increases survival in people with liver failure both because and not because of acetaminophen exposure. So they had their bases covered just in case. The next thing they thought might be possible to have caused the acute liver failure was a drug-induced liver injury. The patient was taking antibiotics after an urgent care visit that assumed bacterial infection, but the antibiotic regimen was only initiated about 2 to 3 days before her admittance to the hospital. And in order for liver failure due to antibiotics, it's usually about 1 to 3 weeks after initiation of the antimicrobial treatment. So the short time frame between the initiation and her admittance to the hospital makes this a very unlikely factor. So the patient also had no other prescriptions and was not taking any over-the-counter vitamins. So they did not diagnose with drug-induced liver injury. So as the patient was recently pregnant, they thought maybe the pregnancy could have had something to do with the liver failure. And so test results showed that the condition was not eclampsia, which are seizures during pregnancy, and that it was not HELLP syndrome. And as you can see up here, HELLP syndrome involves hemolysis, elevated liver enzymes, and an elevated platelet count. And test results showed that none of these were actually present. So eclampsia and HELLP syndrome were pushed to the side, and pregnancy was determined as not to be the factor of the liver failure. The next possibility that could have caused the acute liver failure was ischemic hepatopathy. And essentially, that's when there's a lack of blood flow to the liver. And because of the lack of blood flow, the liver essentially dies and is unable to function. So because the patient was hypotensive upon arrival to the hospital, and she had high bilirubin levels, when her levels are up there 20 milligrams per deciliter, these are both indicative that she was not suffering from Budd-Chiari syndrome, and therefore the fact that ischemic hepatopathy could have caused the acute liver failure was negated. So they did not diagnose with this. The next possibility was that the liver failure was due to viral infection. Prenatal care, however, would have screened for hepatitis B, and the patient also had low risk factors for exposure to hepatitis B. Her aminotransferase levels were also not high enough to indicate that there was a viral infection that could have caused acute liver failure. So liver failure due to viral infection was not diagnosed. The next possibility was autoimmune hepatitis, and lab tests were run to rule out this disorder. The patient was female, and her alkaline phosphatase to aminotransferase ratio was lower than 1.5, and her globulin levels were normal. So the patient, all you need to know from the numbers is that means the patient was already at a very low risk for having autoimmune hepatitis. There was also no evidence of street drug or alcohol abuse, so her score on the International Autoimmune Hepatitis Group scale would be 7. The scale ranges from -20 to 31. 10 to 15 indicates probable autoimmune hepatitis, and 15 plus indicates definitive autoimmune hepatitis. So it's highly unlikely that autoimmune hepatitis was the cause of this with the score of 7. So they chose not to diagnose with this, but it was still kept in the back of their minds just in case, because 7 is still relatively close to the 10. And finally, she was diagnosed with Wilson's disease. Now, the most important thing is that she had no Kaiser-Fleischer rings. And Kaiser-Fleischer rings is a dark ring on the outside of the iris that's due to copper deposited there. And normally that's the number one factor used to indicate Wilson's disease. If you see Kaiser-Fleischer rings, immediately you think Wilson's disease, or if you hear Wilson's disease, you immediately think Kaiser-Fleischer rings. As the patient did not have Kaiser-Fleischer rings, this was not the doctor's first thought. But the patient is within the age range for onset of this disorder, the age range being 12 to 23, and it is a genetic disorder. Katie's going to talk more about what it does in a second. Her alkaline phosphatase to total bilirubin ratios were less than 4.0, and when you combine that with the fact that her aspartate to aminotransferase to alanine aminotransferase ratio was higher than 2.2, the studies have shown that those two ratios together are indicative of Wilson's disease. And patients with acute liver failure that do not have Wilson's disease have a median alkaline phosphatase level of 146.5 units per liter, but patients who have acute liver failure due to Wilson's disease have a level of 20.5 units per liter. Their patient had 22 units per liter, which is indicative of Wilson's disease yet again. So the results of copper and genetic testing were not had to confirm, but a 24-hour urine and serum copper levels were scheduled to be monitored, and the patient was scheduled for a liver transplant, which she received. So when you combine all the ratios and the fact that she was within the age range for onset of this disorder, it was diagnosed that she had fulminant hepatic failure due to Wilson's disease.
All right, so as Alan said, the patient was diagnosed with Wilson's, so I'm going to talk a little bit about what Wilson's disease is, how it is treated, and specifically how it was treated in our patient, and the patient's prognosis. So Wilson's disease is a rare inherited disorder that causes copper to accumulate in your liver, brain, and other vital organs. It is inherited as an autosomal recessive disorder, which means that in order to present with symptoms of Wilson's, you need to receive a defective copy of the gene from both of your parents. So you can be a carrier of Wilson's and not present with any of the symptoms if you only have one copy and potentially pass it down to a child. So why is this important? Copper plays a key role in the development of healthy nerves, bones, collagen, and skin pigment. Normally, copper is absorbed from your food and excess is excreted through bile in the liver. But in people with Wilson's, copper is not eliminated properly and instead it accumulates to possibly life-threatening levels. All right, so treatment. So Wilson's disease is treatable, but early diagnosis dramatically increases the chances of successful treatment for the disorder. If it is left untreated, there can be cirrhosis or scarring of the liver, liver failure, persistent neurological problems, kidney problems, psychological problems, blood problems, So normally a doctor will recommend medications called chelating agents, which bind copper and then prompt your organs to release it into the bloodstream, where it will then be filtered out by your kidneys and released in urine. Other medications may also be used, and treatment for Wilson's is lifelong. In some cases, as in our patient's case, by the time Wilson's is diagnosed, the liver is too far gone to simply be treated with medications, and a transplant must occur. So I'm going to talk a little bit about the transplant technique used in this patient. But first, I want to talk a little bit about how patients are placed in the transplant list in the U.S. So for this patient in particular, diagnosis with Wilson's was critical. In the U.S., the highest priority on the donor list is reserved for patients with liver failure who have a life expectancy of less than a week if they are not in a transplant. And Wilson's disease is the only pre-existing liver disease that allows a patient to be listed as status 1A on the liver transplant list, which is the highest status you can have. So luckily for this patient, she was deemed status 1A and received a donor liver from a 23-year-old brain-dead male who was otherwise healthy. So normally in a liver transplant, the inferior vena cava, which is the major vein to the heart, is clamped by the surgeon, which allows a section of the IVC to be removed with the diseased liver. However, this can decrease the amount of blood returning to the heart, which can, as a result, reduce blood pressure and the amount of blood flowing towards other vital organs. So in order to avoid this, an alternative method called the piggyback method is used, where the recipient IVC is retained and the donor IVC is then joined to the recipient vein. Ultimately, this technique maintains a normal caval flow during the anhepatic stage and avoids the need for a venous bypass. So this is what was used for the patient. And patient prognosis. So since transplantation, the patient has done relatively well. After surgery, she received maintenance therapy with a triple immunosuppression regimen and was discharged day 9 transplant. The patient has since had 3 episodes of allograft dysfunction, which is persistent suboptimal function of an organ system after transplant. It's usually related to problems with vascular supply and urinary flow, as well as medical or immune-related issues. So in this patient, the first instance of allograft dysfunction was relatively minor and occurred during an upper respiratory tract infection. The second and third were due to acute rejection during the administration of subtherapeutic tacrolimus levels 11 and 15 months after transplant. The 2 episodes were resolved with an intravenous corticosteroid and an increase in immunosuppression maintenance therapy. And since then, there have been other complications for the patient. So she's doing well, hopefully. And that's it.
Are there any questions? I have. So, what is one of the complications this that might not be present in other patients? What thinking about? We've heard these talks today. The whole patient life quality aspects of what is something that was. Just go back to you.
The first thing that comes to mind is the lack of Kaiser Fletcher.
That's different. But I'm getting. You're thinking about it as the clinician here. I'm trying to get you from. So we're talking patient care. What is talking? She's in front of you, sitting down. What would you ask? What would be one of
I think the fact that she had such a pregnancy at such a young age was really indicative of or not indicative, but kind of led to these other possible diagnoses. In addition to the fact she just had bronchitis, or what they thought was bronchitis, they never said that it wasn't. But trying to balance this very young mother who's from urban New England area. She's from outside of Boston, and she was in liver failure and had just finished with a complicated pregnancy. She was the child was preterm. She had this placental abruption, which is a very serious complication, and then trying to figure out there were great possibility for this to been a case of medical abuse with drugs or any other types of things, but trying to understand the idea that it wasn't to rule out postpartum depression, which is very common, especially in young mothers. So going off of that, yeah.
And on top of that, if she has Wilson's disease, and the father of the child might be a carrier, there's the chance that her child will have Wilson.
The first thing that I would the baby do? Presumably, she's not able to breastfeed. Cocktail, presents, etc., etc. Just thinking about what her ability to is like, how stress does for treatment for Wilson's disease. How is that choices formula or finding what I that's one thing that was immediately after we went through all this. She had surgery. How do you babies lot mom? Is her mom part of this? Or her dad? How are they caring for her? She's a liver. That's like to me that's pretty. You can imagine it was pretty traumatic.
Yeah, that's how I was respond to the question. I did like extra research on. I was trying to find more of like patients diagnosed with Wilson's who were pregnant, and I like the timing of her diagnosis was very unfortunate because like a lot of what I found it was like how to treat patients who have Wilson's while they're pregnant, and things go like a lot more smoothly. I think all of other like pregnancy and especially like pregnancy with a abruption is very like rough on the body, and then to also be diagnosed with.
The only other thing, well, there's another obviously talk here about liver failure, but one of the things you didn't put any of the actual blood. You talked about the things that is that the aminotransferase levels in this patient were elevated but not radically. They were elevated but not radically. So they were looking at the ratio, whereas specifically a number you guys didn't talk about the gamma transferase that was blown through the astronomical and whatever the other. But you'll notice in that panel that those are actually not. It's kind of an inverted. Know if that's indicative or not. Did you guys come across? I don't know. Or even just a percent of liver. If you don't, it doesn't matter.
I do know that like her being of Southeast Asian descent is does increase her chances of having Wilson's disease. It is a genetic disorder commonly associated with that background.
All right, thank you.